Kanski lecture series, and this is going to be the Uveitis part 3. And in this part we are going to discuss about the non-immunomodulator therapy for the non-infectious uveitis. So basically immunomodulator therapies are the instead of steroids you used other immunomodulators, which are that modulates the immune system. So about if the steroids are not effective, if you want the patient to be steroid sparing, or if there is a systemic disease therapy. Introduction. The therapy plays an important role in modifying the immune response and should be supervised by the multidisciplinary teams that includes an ocular inflammatory disease specialist. Shared decision should be made on when to start the treatment and subsequently on whether to modify or withdraw treatment. The specific medication to be used should be based on the type of uveitis and the known efficacy and safety profile of the proposed agent. Before starting treatment, careful informed consent should be taken detailing the advantage and potential side effect of the medication and emphasizing the need for the regular follow-up. So basically, it is a multidisciplinary team approach to start a patient on a immunomodulator therapy, and you basically guide the patient that what are the advantages, disadvantages, and follow-up advice. Active infection, especially tuberculosis, should be excluded, and hematological, renal, and hepatic function should be checked. So you have to take some blood test before starting such treatments. You have to get LFTs, RFTs done to check if any of this is deranged, because these medication typically affect all the functions. The aim of treatment is to obtain a steroid free remission of the disease. So this is a pseudohypopion formed by the crystalline steroid following intravitreal triamcinolone injection. So what are the indications? So there are certain indications. So one is that you immediately start immunomodulator. Next is that in early cases you start treatment and as an alternative to steroid. So what is the immediate treatment? For example, systemic lupus erythematosus with retinal vasculitis should be treated with immunomodulators immediately. Behçet disease with the retinal vasculitis. So basically, if the retinal vasculitis and having a systemic inflammation, then you start immunomodulator directly. Then early treatment should be considered for sympathetic ophthalmitis, Vogt-Koyanagi-Harada syndrome, birdshot retinochoroiditis, serpiginous choroidopathy, multifocal choroiditis, and panuveitis, juvenile inflammatory arthritis. So basically, inflammatory is a sympathetic ophthalmitis, VKH, birdshot, serpiginous, multifocal, and juvenile. As an alternative to steroid therapeutic, inadequate response to topical and periocular steroid on an oral dose of greater than 0.5 milligram per kg per day prednisolone, intolerance to systemic steroid, or as a steroid sparing measures. So basically you can give as a steroid sparing agent, and when there is no response to steroid or any kind of oral steroid, topical steroid, or a patient is intolerant to steroid, or you want to give a steroid sparing measure, so you can start immunomodulator therapy. So for the ocular causes, acute disease that is right threatening or chronic and persistent exudative retinal detachment or disease involving the macula. So when there is a retinal detachment, there is a disease involving macula, you can start immunomodulator therapy. So what are the basically side effects of these medications? These needs to be discussed with the patient and regular monitoring should be undertaken. In the doses used, the commonly prescribed immunosuppressive azathioprine, methotrexate, mycophenolate, mofetil, cyclosporin A steroid do not increase cancer mortality. The use of azathioprine monotherapy or anti-tumor necrosis factor (TNF) monotherapy is associated with a small but a statistically significant risk of lymphoma. The risk is higher with the combination treatment. So basically, you just give an immunosuppressive therapies, which are like azathioprine, methotrexate, mycophenolate, cyclosporine, and steroids. So these are not these are all immunosuppressive and they do not increase the cancer. But the use of azathioprine monotherapy and ATN is associated with small but a risk of lymphoma as well. As a general rule, most of these medications are well tolerated, but side effects like headache, tiredness, GI upset, bone marrow suppression, and increased risk of opportunistic infections have been reported. Individual agents have complications that are specific to that particular medication. Classes of medication. So there can be antimetabolites, there can be inhibitors of the calcineurin signaling in the T cells, alkylating agents, by pharmacologicals. So antimetabolites are contains methotrexate, mycophenolate, mofetil, and azathioprine, and which inhibits the purine metabolism. Inhibitors of the calcineurin signaling in T cells: cyclosporin A, tacrolimus, veclosporin, and sirolimus. Alkylating agent, if there is a cyclophosphamide and chlorambucil. Biopharmacological. This is a rapidly changing field, and new agents are constantly evolving that are effective in suppressing ocular inflammation. Infliximab, adalimumab, and etanercept, golimumab, and certolizumab are the anti-TNF alpha monoclonal antibodies that are registered for the use in non-infectious uveitis. These agents take time to suppress inflammation, 2 weeks to 3 months. Topical and systemic steroids may be needed initially to control the acute inflammation. So these are just the classes of the drug that we can use to control as an immunomodulator therapy. So next is a uveitis in spondyloarthropathy. So basically now we are starting that about the systemic disease, and in this case spondyloarthropathies and the uveitis in that case. So spondyloarthropathies are a group of disorders featuring HLA-B27 positivity and enthesitis is a common factor. There is often a family history of one or more of the group, which comprising ankylosing spondylitis, undifferentiated spondyloarthropathy, psoriatic arthritis, reactive arthritis, Uveitis syndrome, and spondyloarthropathy with inflammatory bowel disease, ulcerative colitis, and Crohn disease. So basically, we are discussing about the pair, which is very common with the HLA-B27. Pair P means psoriatic arthritis, A means ankylosing spondylitis, I is inflammatory bowel disease, and R is Uveitis syndrome. They are often referred to as the seronegative spondyloarthropathies, in that rheumatoid factor is not present and pathophysiological basis differ. So in this case, usually it is called seronegative because the RF factor is negative in such scenarios. The American Uveitis Society has recently endorsed the use of biological blockers such as infliximab for second-line systemic immunosuppression in a vision-threatening chronic uveitis. So you can use a biological blocker infliximab in a case of vision-threatening chronic uveitis in a case of spondyloarthropathies. So first we are going to discuss about each of them. Monoclonal antibody treatment adalimumab and infliximab has improved the prognosis in patients with vision-threatening chronic uveitis. So first we are going to discuss about the ankylosing spondylitis. So basically it is the inflammation of the spine or axial skeleton. Ankylosing spondylitis AS is characterized by inflammation, calcification, and finally ossification of ligaments and capsules of the joints, with resulting bony ankylosis of the axial skeleton. So what is that? Basically there is going to be the inflammation, that this is spine and they are capsules and they are having ligaments as well. So inflammation of the ligaments and capsule, and there can be calcification and finally ossification. It more commonly affects males, of whom 90% are HLA-B27 positive. Systemic features. Presentation is commonly in the 3rd to 4th decade with the insidious onset of pain and stiffness in the lower back or buttocks. So basically the patient usually present in the 30 to 40 years of age, and there will be the gradual onset of pain and stiffness in the lower back. Spondyloarthritis causes progressive limitation of the spinal movement. So patient will be unable to do the spinal movements, and eventually the spine will become fixed in flexion. So we can see figure 12.11. So this, this spine is now fixed in a flexed position. Spinal stenosis and fractures may occur. Enthesitis is characterized clinically by inflammation and pain at ligamentous attachment to bone. So whenever there is a ligament, the ligament is attached to bone, and at that point, when there is an inflammation, this is called enthesitis. Cardiac complications are rare. Radiology of the sarcoiliac joints, sacroiliac joint, which is basically the joint between the sacrum and the ilium, shows a juxta-articular osteoporosis in early stages, followed by sclerosis and bony obliteration of the joint. So there are going to be the osteoporotic changes in the skeleton, and which is followed by sclerosis and bony obliteration. Calcification of the spinal ligament give rise to a bamboo spine. Rheological changes often predate clinical symptoms. So this is a spinal sclerosis. B is showing sclerosis and bony obliteration of the sacroiliac joint. You can see there is an obliteration. Next is an ocular feature. So what is going to be the ocular features in the case of ankylosing spondylitis? Acute interior uveitis is by far the most common ocular association and occur in about 25% of the patient with ankylosing spondylitis. So most common of ocular presentation is acute interior uveitis. Approximately 25% of the males with AAU will have a anterior ankylosing spondylitis. Either eye is frequently affected at different times, but bilateral simultaneous involvement is rare. This is often no correlation between the severity and the activity of eye and joint involvement. Chronicity occur in a few patients. HLA-B27 patients, AS patients tend to have a worse disease across a range of parameters, including earlier onset and greater intensity of inflammation with an increased frequency of complications. Other ocular features include scleritis, episcleritis, keratitis, and mechanical ptosis. So all of these can be the complications of the acute spondylitis arthritis. Next is a reactive arthritis, which is also known as Ritter syndrome. Reactive arthritis, also known as Ritter syndrome, is characterized by the triad of the non-specific urethritis, conjunctivitis, and arthritis. So major is the conjunctivitis. So what is this? They're going to be the urethra inflammation, urethritis, there can be conjunctivitis, and they're going to be arthritis. Around 75% of the patient are positive for HLA-B27. A range of infective agent can trigger the syndrome. So it is one of the disease in which certain infective etiologies can trigger this kind of inflammation. And around 4% of the individuals after enteric infection caused by a range of organisms including Shigella, Salmonella, and Campylobacter. Chlamydia, pneumonia, respiratory infection, and other also precedes Ritter arthritis. So next is a tip: patient with uveitis secondary to the various spondyloarthropathies are often HLA-B27. So what is going to be the systemic features of the Ritter syndrome or reactive arthritis? So presentation is with the acute onset of malaise with fever and dysuria 1 to 4 weeks after linked infection in a patient aged between 20 to 40 with arthritis that may be preceded by conjunctivitis. So first of all, they're going to be arthritis. So first of all, there is going to be urethritis, and then there is going to be conjunctivitis, and then there is going to be arthritis. A variety of other features may be present, though not always the defining triad. Next is the peripheral oligoarthritis. So what joints are usually involved in the case of arthritis? Peripheral oligoarthritis is acute, asymmetrical, and migratory. 2 to 4 joints tends to be involved, most commonly the knees, ankles, and the toes. So basically it is going to be the peripheral area of the are going to be involved, and they're going to be the 2 to 4 joints are going to be involved, most commonly knees, ankles, and toes. Next is the spondyloarthritis. Spondyloarthritis affect about 50% of the patient manifesting with the low backache, this sometimes become chronic. So spondyloarthritis can also be the feature of the Ritter syndrome. Enthesitis manifest with the plantar fasciitis, Achilles tendinosynovitis, bursitis, and calcaneal periostitis. So these are all the ligament area attachment to the bone that can be affected. Plantar area, Achilles tendon, bursitis, mostly the um, legs are involved. Reactive bone formation in the later may result in a calcaneal spur. Next is going to be the mucocutaneous lesions. Include the painless mouth ulceration, succinate planitis. Basically, it is inflammation around the genital area of the males, and keratoderma melanoregica, skin lesion resembling psoriasis. So basically, just like psoriasis, they're going to be the skin lesions involving the palms and soles. Genitourinary involvement include cervicitis, prostatitis, and epididymitis. So basically, many of the other organs are also involved in this. Aortitis occur in about 1 to 2%. So this is, you can see a keratoderma, melanoregica, and reactive arthritis. So you can see the psoriatic like arthritic like lesions in the case of a patient that involves the palms and soles. So what is the ocular feature? So in this case, not acute anterior uveitis can be the ocular feature, but most commonly conjunctivitis is the feature of the Ritter syndrome. The eye is involved in 50% of the cases with urogenital itching infection and 75% of the enteric Ritter syndrome. Conjunctivitis is very common and classically follows urethritis but precedes arthritis. So basically, urethritis first, they're going to be urethritis, then they're going to be conjunctivitis, and then there's going to be arthritis. The inflammation is usually mild and bilateral and mucopurulent with a papillary or follicular reaction. Spontaneous resolution occur in within 7 to 10 days and treatment is not required. Some patients develop peripheral corneal infiltrates. Acute anterior uveitis occur in 20%. Episcleritis sometimes occur. So basically, you know that there are going to be urethral urinary inflammation that can cause a reactive arthritis, but also there are enteric organisms that can cause the Ritter syndrome, that may include Shigella, Salmonella, Campylobacter, and Chlamydia pneumonia, which is a respiratory infection, can also cause the Ritter syndrome. Next is the psoriatic arthritis. Up to 40% of the patient with psoriasis develop arthritis. So most of the patients, basically psoriasis is a skin lesions that are basically immune mediated problem of the patient, and sometimes the patient with the psoriasis develop arthritis. This is called a psoriatic arthritis. The arthritis is more common in whites than other racial group and affected both sexes equally. There is a first degree family history in 40% or more, and many genetic markers have been identified. Presentation of a psoriatic arthritis is usually in the middle age, later than the skin features. There are multiple types of psoriasis. Plague type, the most common form, is characterized by the well demarcated raised silvery inflamed plaque. So basically you have to identify the lesion. So this is the plaque type lesion, which is basically elevated. This is inflamed, this is having a reddish, and there is a silvery flaky inflammation plaque. On the scalp, it will present on the scalp. It can be present on trunk, arms, and legs. Psoriatic erythroderma features widespread exfoliative skin changes with associated inflammation and pustular psoriasis. Inflamed but not infectious, pulsatile, limited or generalized in distribution. So basically, writer is trying to define the three types of psoriasis. Plague type, which we discussed. Then there is a psoriatic erythroderma, which includes the widespread skin changes, and they're going to be, the third is pustular psoriasis, in which there basically non-infectious pustules are formed. Dale-Jadis dystrophy include pitting, transverse depression, and uh, onycholysis. So you can see this is a onycholysis. Arthritis is typically asymmetrical and involves the distal interphalangeal joint sausage disease. Some patients develop enthesitis. Ocular features: acute anterior uveitis occur in about approximately 7%. Conjunctivitis, marginal corneal infiltrate, and secondary Sjogren's syndrome may occur but are uncommon. So basically, acute anterior uveitis about 7% occur. There can be conjunctivitis, marginal infiltrate, and Sjogren's syndrome can also occur in a case of psoriatic arthritis. So basically, next, the inflammatory bowel disease also causes the uveitis, but it is discussed in later in this chapter. So that's it for the uveitis part 3. See you in the next lecture.